we had a EMS day for a fire department last year. One of the scenarios I wrote was to just basically see what their thought process was, and I'm curious to yours now. To the scenario was, it was a heart attack that caused an MVA that caused trauma. They caught the heart attack in the back of the ambulance. They treated it with heparin, Brilinta, as they should, and then transport to a physician like you or surgeon to then fix the problems. What might you run into with that?
And relative to the MI, is that we're going to, well, relative to heparinization, it's a double-edged sword, and we have to be careful. Right now, it's a standard trauma workup. I mean, we're guided by advanced trauma life support in the trauma bay. That is our primary secondary survey, and then definitive care. Often, in this day and age, CT imaging has been a powerful tool for what's next, how to define definitive care, injury pattern, and so forth. If the injury pattern is merely orthopedics, right, or a fracture pattern, then the patient will still need cardiac care in our unit, and it'll be on our service. Cardiac services will be consulted, and the issues of heparinization or anticoagulation will be debated. But the fact is they're under our care, and in that first 24 hours, bleeding even the fracture sites will be bleeding. So right now we want to keep them from anticoagulation and use the benefits of their system. If the cardiac issues are so severe and outrank those the injuries, then obviously alternative management would occur, and cardiac management, including arteriography, angiogram, and management from there would be indicated.
Awesome.
Yeah, I kind of cringed when you said that and they got Brilinta and heparin.
Increased risk of bleeding for 200?
Yep. For 800, Alex. I would, in that case, if you have a STEMI and some trauma injury, should be a call to med control.
Yeah,
We're going to tell you to hold those because the risk to that patient outweighs any possible benefit. Same thing when we have concern that if they're having a STEMI and they're having ripping, tearing chest pain, if they're dissecting, giving them aspirin and Brilinta and heparin is going to be detrimental to their care.
And the way that scenario was written was just that. I mean, call med control before you start anything. You've recognized the STEMI. You've recognized the trauma injury.
And have us sorted out. It wasn't a trauma patient. It was a STEMI patient that I had that I was sitting there with my interventional cardiologist. We're looking at a CAT scan because she had abdominal pain. We're like, well, is this a dissection or is this a STEMI? What is this? So in that case, what would happen is I wouldn't give any meds, give them two large bore IVs, start some fluids, bring them to us. We're going to do our initial exam. We're going to scan them head through pelvis, right? And if we don't identify any terrible injuries, it's going to be a conversation between trauma and interventional cardiology of risks and benefits. And if the patient's conscious, include that patient to have them help guide, like, we can give you these medications, but if something's tamponaded right now, we might take away your body's ability to stop that bleeding, but you're also having a heart attack. And then, again, if it's a trauma, is that a dissection that's now causing the STEMI because they've had a type A dissection that we just had in our November lecture of 2024 of education, that it's dissecting of the coronaries, and that's what's causing the issue. And we're going to treat that medically and surgically very different.
Yeah. Is there any cases that you could see with severe hemorrhage and trauma that might not be a benefit to us going along with TXA for you?
The controversy over TXA, you're leading into a controversial area, and I don't know why it's controversial. It's not controversial to me. It's been borne out, and it came out of our military experience. however, I have colleagues that still feel that there's too much of a risk to use an antifibrinolytic relative mostly to thrombosis, venous, thromboembolism. But the fact is, man, it's been borne out, and I don't personally have a problem using it aggressively. Obviously, it's in the field here in 1 gram doses, and I feel as long as it's within the time frame, the 3-hour time frame of the injury. So I forget how you phrased the question, but the controversy. My colleagues, I do have colleagues that still are wary of it, but I'm not.
I'm not.
I think
either.
that answers that. I mean,
Yeah. I don't know of any fours in Ohio.
No, there's no fours.
So
there's no, and it's been discussed. 4 it does not have surgical services, and so it's generally in an emergency department. It's interesting. I've seen it in Texas where they're establishing 4s, and freestanding EDs can be a 4.
Oh, yeah.
Yeah.
Well,
Because you got a CAT scanner and you've got a doctor.
Yeah, it's absolutely ludicrous, I think, because you're basically you're going to again if it may work. Texas does some strange things, but I'm not a big fan of 4s. 4s were made for really
Almost like a critical access trauma center.
Very much so. Critical. So like a Conneaut could be a
4. Sure.
Yeah. Where you put the emergency medicine physicians and staff there, but they should have a place where they can admit minor trauma.
Sure.
And
I see your point there.
Observation.
Like isolated ortho injuries. If it's like
that's right.
sharing height fall, hip fracture, on a thinner, we can manage.
There should be, and again, there should be a bed size commensurate, like 23 beds or 20 beds. And if it goes to the level of ICU care, they need to be moved.
Yeah, sure. And that's, I think it's just good. I think you explained all the trauma center, the levels, great. And, what the care means there, essentially. We're very blessed in Northeast Ohio compared to across the United States. We have a plethora of trauma centers, which is excellent for us, because pretty much, I don't want to say every hospital we transport to, but, when we taught trauma education, for the most part in Ohio, I think you can pretty much be anywhere and in 60 minutes be to some form of a level of trauma center, whether that be by ground or by air in 1 hour, right?
That's accurate. No, Ohio, to a great degree, Ohio, Pennsylvania, Michigan, there's a trauma center on every corner. Are all well served in that capacity. Ohio has some Southern Ohio has some rural regions that really do need, both from an EMS standpoint and a trauma center standpoint, to be looked at more critically in terms of access to care.
Sure.
But around Cleveland, Columbus, Cincinnati, Toledo, Akron, there's a plethora.
Sure. Of everything we need for those resources, right? And since we've been talking about trauma centers a lot, before we really get to dig into more some of the things like Caleb was talking about, I want to talk about some treatments. We'll talk about TXA, transition of care.
Okay.
So we keep talking about trauma centers and the American College of Surgeons. So for some that do not know, our trauma centers are governed by the American College of Surgeons. And then in theory,
let's
verified.
Let's call it verification. That's what they call it. The state will say they do not designate trauma centers, that the college does. The college doesn't designate, and it's very emphatic about that. So in a sense, the centers are selecting themselves and through the verification, designation occurs.
Gotcha. That'd be a better way. Sorry, I misspoke. So,
Yeah.
so the verification process and the whole goal of that, with being verified as a trauma center, then we've taken all these steps. Whether you're at a 3, a level 1, all of these steps have occurred, and EMS protocols were developed that were signed off on. I know you and I talked about that earlier. How does EMS education happen? How do EMS protocols get developed? They get developed with, in collaboration with our level 1, with our trauma surgeons, just like Dr. Tinkoff, who's sitting here. And, the verification process is built on how do we always improve, right? How do we always want to do better? How can we always do that next thing? Not to quote Dan Ellenberger, right? How can we do that next thing better than someone else, right? We're always trying to improve outcomes, and being part of not only our UH network, but you touched on a little bit of the NOTS trauma systems, which has come up, in our collaborative efforts with even different systems that might not be university hospitals, but being able to collaborate with them for maybe, Metro has a burn unit resource that, we do not have, but that's what's best for the patient. That's where we're going to send the patient. So having these systems of access really ensures that, we always talk about the right patient. I want to take the right patient.
Right patient, right place, right time.
Right time, and that's how we have successful outcomes, right? That's how we can return that patient to more of a normalistic life, a better life, and that's what we're looking to do.
I think the important thing to recognize this verification designation, it is what the American College of Surgeons Committee on Trauma, it's really the American College of Surgeons Verification Review and Consultation Program that has been developed to verify that, in this case, about 150 standards or so are met, and they're more rigid than they ever were when they were criteria, because they have risen to the level of standards because to some degree they've been validated, either through evidence-based studies or at least outcomes at centers where that methodology worked.
Yeah.
So, and worked well. So, it is, but it's a verification. The designation process. Why doesn't the state want to designate? Well, I told you the state of Ohio does not like regulation, and therefore it wants areas of the state to do exactly what UH did, and what NOTS is doing, is organize around some local organization or agreement, in this case, to work with EMS and deliver patients, as you said, to the right patient, right place, right time.
Sure, and that's
that's
huge.
That's what Ohio has done, without much overbearing regulation. Yeah. Very unique.
Without being told so, basically.
Correct. Without force, without this is the law, you shall do this, right?
But it recognizes the local differences in the areas. This has a different. Northeast Ohio is different than Southwest Ohio in terms of how it arose, what its EMS structure is, and so forth. So
sure. Yeah, I mean, we have a special. I think. Yeah, to circle back to that, I think we have a special system. Yeah. Through agreements and through collaboration between 3 different hospital systems, which make up Southwest as well. So Cleveland Clinic, University Hospitals, Metro, and Southwest General that make up Northern Ohio trauma system. So we have our own system within UH. We're also part of a regional system, if you will, through NOTS. Yeah. And then, that's how we have regional protocol development. But all those things, as you start to grow it versus, well, this is Geauga as a level 3, and then we're part of UH's system, and then we're part of NOTS, and then you include protocol development in that. You include regional, I don't want to say regionalization, everybody freaks out over that word, but like regional protocol, because we're trying to standardize care based on evidence-based medicine, and that's how we save more people, whether it's in the back of the ambulance or it's no different when we take them to a level 1 trauma center. They're using best practices, evidence-based medicine to try to save that patient.
Yeah,
so
but regionalization is a good thing from the
sure, and the consolidation of resources, right,
that,
or different
and
options,
you guys
different
all know
centers.
like how many times you go on a mutual aid call, right?
Yeah,
you want to be
right.
able to say that if place A is under University Hospitals and place B is under Cleveland Clinic, well, those are in the same trauma. They're going to have the same trauma care there. They're
Yes.
going to go to the same local trauma center. They're going to get that exact same care.
Well, I mean, and we've all been on EMS-wise calls where we're mutilated for maybe just a medic only, and you get in the
Correct.
back of somebody else's ambulance to have the same medications, to your point, at my disposal or protocol,
Yep.
makes that much more of a smooth transition as just standing there being like, I can't do anything for you. Why am I here?
Yeah.
Yeah, and I think I think that's really huge to be part of those systems, develop those protocols. Those are some of the things that we really wanted to discuss. Why are all these things important? And I think my point too, and a lot of this was like you and I discussed in some emails as to why I thought this episode was so important is because until I worked at a hospital, I just understood the protocols, the development, treatment, and then my 15 minutes is over, and then I gave Dr. Tinkoff my patient or Dr. Hill my patient, and then my part stopped, and I didn't really see the backside of that, right? All the work that goes into a trauma program, all the not only just for a re-verification survey, which I've been part of 2 of those successfully, and I enjoyed them, which is kind of weird because they can be pretty firm and hard and difficult, but I have a big mouth, so it makes it pretty easy to talk to people, which helps. But that's a lot of work on, I think, the trauma program manager, the trauma medical director, everybody that's part of that trauma program. And I think that's the side we don't necessarily see in EMS. When we transition a care to the emergency department, our part stops. But that's where the continuation of all of the things we just discussed are so important. And we don't really see that side in pre-hospital, right? We don't see the surgery, we don't see the program management a ton on the backside, or the loop closure, or we're getting really good at feedback, I think, in our EMS system. And there's the platforms of EPCRs that we use. I know Deanna gives feedback through Health EMS. So if you have a trauma and they have an ISS score of greater than this number, then it automatically sends feedback to like Geauga County squads. With ESO, one of our other EPCR platforms we're going to be using, you're going to be able to see outcomes. So you could log in, you might be able to see CAT scan imagery. You're going to be able to see some of the ER diagnoses, some of the things that happen in surgery care. So that's where I think at UH we're really doing something special with trying to bridge that gap of, showing that part of versus we dropped them off, we don't know what happened to them. I think we do a really good job in our system of feedback because that's how we continue to learn, right? From a pre-hospital standpoint.
As one of the guys that QCs like all the departments in Geauga County, EMS runs for our system. I can tell you the number one feedback that I get from those departments is, we want to hear what happens to our patients after we drop them off. And I don't blame them.
Sure.
Did what you do work or not? And that's what they want to know. And not only that, but you get a little bit of an advocacy there. You're kind of part of that patient's life now. I think UH does a phenomenal job of bridging that gap to say, okay, I have the opportunity to log in, see what happened, especially if you flag that for comment. I'm going to get back to you and say, oh, this patient was admitted or discharged, and this is what happened. And I think that's awesome. But to your point with the protocols, we're so proactive in our protocol system. It's phenomenal, because what I think people don't realize is a lot of people say that we're too proactive in some cases. Like, why do I have to do all this? Why don't they pay me more to do it all? Well, first of all, that's another argument. But second of all, everything that we've put together in our protocols, Scott can tell you, you guys sitting here can tell you can tell me, feeds into how that patient gets treated down the line as well. So,
Sure. Yeah, like Dr. Tinkoff mentioned, it's like, so surgeons take ATLS, right? So advanced trauma life support. And then pre-hospital, we're doing ITLS.
That's right.
Or we're doing PHTLS. And so, and some of the things on the notes are, we're pushing out, trauma pushes out education, where we go to all of our ambulances that are under our protocol. We go out, we do that education, so that when, that trauma patient is getting good pre-hospital care, they come into the emergency room, they transition care to now the hospital. We're doing the same thing. We're speaking the same language. We're looking at the same items that, what could essentially kill this patient in the next 15 minutes is our world, or whatever your transport time is pre-hospitally, to, what might kill this patient in the next hour?
Right.
What might kill this patient in the next 2 hours? We're looking at those immediate life threats and how to fix that.
And I can tell you firsthand, I've been in this county doing EMS for 21 years now. Things come and go, but they're evidence-based as to why they come and go. We didn't just get rid of mass pans. There's reasons we got rid of mass pans.
Yeah, remember when tourniquets were bad, right?
Yeah,
Let's go on a history lesson. Tourniquets
Watch
were
Rambo,
bad.
First Blood, right?
Tourniquets were bad, and
release that
backboards were
tourniquet
good.
every 10 minutes, or else.
Now it's spine motion restriction is great. We want to do C-collars, and then tourniquets are also great. And we're out with the backboards. So it's like, because all of this evidence is feeding what we're doing, because there's been success stories based off of clinical trials, studies,
and not to pat
evidence-based
myself
medicine.
on the back, but our EMS educators are doing a better job also. My students are asking me, why aren't we giving lactated reaners for trauma patients, because it has a 7.0 pH level and normal saling's 5.0. The fact that they're asking those questions tells me that this is awesome. They actually care. I mean,
that's huge.
Yeah, that's actually a great comment. I wish everyone would have. Well, hopefully everyone hears that. Yeah, that needs to be recognized. That the acidotic nature of normal saline.
I think another thing that the trauma programs do that actually EMS doesn't see, we as docs don't see, it's the prevention. So there's a big portion of those programs that they've got to go out there, they have to engage in community and talk, and they have to identify what are the big risk factors from a trauma standpoint in my community and how can I decrease risk to those patients. Obviously for Portage County it's motor vehicle collisions and it's blunt trauma essentially. But we have lots of programs out there to help educate the public to keep them safer, so that way we don't even become patients of ours.
Yeah.
And that's a lot of the work that ACS is behind. Obviously local trauma programs are behind to help. It's that old adage, an apple a day keeps the doctor away. If we can do an ounce of prevention, it keeps the pound of medicine.
And that should be macro all the way to micro. I mean, the other day I was at our community. We have one of the largest assisted living type 5 structures in Geauga County. And I was there giving prevention talks on falls and trip hazards and hypertension and CVAs and heart attacks. And we didn't have to do that. That was on our dollar, but we've done resource and research that says that that's the main problems out of that facility. So let's talk about it.
Yeah.
So
and that's your data. That's our EMS data, right? That we're looking at, and then we get into, let's talk about UH's trauma network right there. So we can look at that data. Like, what's the number one entry into UH Geauga? Same height fall, right? Second one is motor vehicle collision. So we look at how can we do education to try to prevent falls, slips, trips, someone, same height fall that hits their head that's now on a blood thinner. Now it's a limited HIA right out of the gate. So it's like, how can we try to prevent that? And then you talk about motor vehicle collisions. How can we partner with local law enforcement for, safety days, wear your seatbelt, don't drink and drive, all these types of things we want to try to prevent so that we don't have to get that trauma patient. And that's all based off of data, right? That's the whole main goal of what we're trying to do. If we can prevent it, phenomenal.
Well,
right?
alcohol plays a huge role in the cause of a lot of trauma incidents and then complications of their care.
Well, I would point out that of all the things, gravity is and that's not going away.
Darwin syndrome?
Yeah.
No, but I can pick that rug off of the floor and that's going to stop someone from tripping.
We have some of the best fall prevention efforts going on in our network of hospitals of level 3s that I see, because I'm a reviewer of trauma centers as well. I'm an ACS reviewer that I've seen out there. Our programs are invested in fall prevention, just like you said, at all levels, from the EMS level to the recovery level, with our occupational and physical therapists and rehab specialists. So we're fully invested there in terms of the recovery from falls from the event, but also the prevention of the event to the best of our ability. That, however, it's somewhat inevitable, that a fall will occur. It's how resilient you are, and when you have a frail individual, not so, they're going to get injured. and making sure that their recovery is the best it can be. And so, talking about prevention, I mean, we have started, one of the things I'm very proud of is we've started a violence intervention program at Cleveland Medical Center based on the principles of one, interrupting retaliation by using a hospital responder that really is who's educated in de-escalation and basically is a credible messenger to generally not the patient but the family who's there, and then trying to and the community that comes out to calm things down. These are mostly in urban events that are associated with firearm injury or assault. Probably the best program, one of the best programs in the United States, started at Metro Health and has continued there. So we're modeling in that manner as well, and hopefully through our Northern Ohio trauma system arrangement. And thirdly, motor vehicle crashes in the U.S. Hit a low right before the pandemic, and coming out of the pandemic, we've seen them go up. And just driving here, the speeds that I saw on the road are fairly remarkable.
Yeah. Oh yeah. Plus, and everybody that you see on the roadway is typically texting, replying to an email, right? I think that's a lot of it. A lot of it is distracted
the majority of our roads around here have 110 mile per hour impact possibilities.
But yeah, that's right. But our trauma centers are also invested in especially in young drivers, in making sure that we don't forget that element of trauma prevention, automotive injury, and of course we have ATVs.
Yes. I had one. Oh yeah. We probably everybody sitting at this table had one. Yeah. Oh yeah.
Yeah.
And you never operate an ATV under the influence. Ever.
And you always wear your helmet.
You always wear your helmet.
You're
and
always
eye protection.
Yep, and clothing.
What about tractors?
Yeah, tractor. Yeah, that too, right?
So
A-Shift's going to take a shot right now.
But again, those messaging is very important, and that's what these programs, the trauma programs at these centers, are focused on in their prevention effort, and that's why the personnel in those programs, mostly the trauma program managers, do extraordinary work and are tasked with all these things, as you said, during the verification process.
Yeah, and I think the big thing too, and the takeaway point from that is, I tease Dan, our boss, but it's always about building life-saving communities, right? So no different than Caleb's using his fire department example out doing fall prevention, and then our trauma program's doing fall prevention, and that overlaps, right? And our hospital located down the street, and this works out well that we're using, Munson Fire Department and University Hospitals Geauga, Medical Center, that we have that overlap right now because we're part of the community, right? So when that patient comes to our hospital, right, where they're seeking care, their family member might not necessarily want to be transferred. So we want to be able to take care of them as best as we can in the community, keep the family in the community, get the recovery in the community. And that's what it's really all about, this huge global system that we're trying to just explain, a little bit of the backside, I think, to EMS providers that we just don't see.
Yeah.
And I think that's huge.
Put the word good EMS providers on that. There's all kinds, but good EMS providers take it a step further than just responding to those 911 calls.
Sure.
While they're there, be a patient advocate and look at trip hazards. Look for reasons to educate while you're there. I mean, it sets somebody aside. It really does. If you come to work, I like the quote that I heard the other day was, how much of your fire department is doing actual work? And the quote back is 50%. How much of your guys are actually working? 50% of them. And it's like, well, that's not the case everywhere. No. But if only 50% of your guys are actually caring, let's fix that.
Sure.
But places like University Hospitals, Metro Health, Cleveland Clinic, they're giving those EMS opportunities to better themselves. I mean, the equipment we can receive, the training we receive, there's no reason not to do better.
Sure. I think the big thing with pre-hospital care is we're going to talk about the role EMS plays in that trauma trauma patient in their care. I think we really did well describing how the transition of care from, we take care of a patient pre-hospitally, transition of care into the hospital.
Does that
And
move you when
and
you
that
do this?
transfer of it. But I think one of the things that first starts off with is, well, we have activation criteria, right? So we have, specific to, UH, we have
Well, specific to the system as well.
Correct.
To your point, if somebody was to say full or limited trauma to one of our EMS providers, probably in Geauga County, not many of them would know what you mean. So,
well, there's different criteria. So the level 1, correct me if I'm wrong, Doc. The level 1 has their full and limited activation criteria.
They do.
And then the level 3s have
activation.
they have full and limited as well.
Yeah.
And they have full activation. So let's say, I'll just give an example for like Geauga. A full activation at Geauga would be like a gunshot wound victim with a systolic blood pressure less than 90, right? So we know that patient is probably in some form of hemorrhagic shock in a broad brushstroke there.
And that'll be a penetrating trauma to the box, right?
Yep.
It's chest, abdomen. It's
Right.
not necessarily just
And
extremity.
groins.
And groin.
Yeah. And then I've kind of triggered it just to overlap with a systolic blood pressure less than 90 would give me the full. And then I dump down to a limited would be like a rollover MVC at 45, a rollover or an MVC at 45 miles per hour. Now that's being triggered more by my mechanism. And then if I want to do like a limited HIA would be my gravity, standing height fall, I hit my head and I take Plavix or Eliquis, Pradaxa, those types of things. So those are the activation criteria which are billed out, and there might be some variance from a level 1 to a level 3. Am I accurate in saying that?
Yeah, correct. But the fact is they're monitored for accuracy of triage and resource, because you're using a larger amount of resources when you call either of these activations, including the HIA. You're changing, the dynamic of the emergency department at that time, and you're bringing additional resources down from other departments and changing their operation for that period of time.
Yeah, so all traumas are going to affect the emergency department, obviously, and then a radiology department as well. And same with like
OR and the ICU and for fulls. So and the blood bank. So and lab.
And EVS, because they got to clean a room if you don't have a room available.
So it's a big thing. There's in the early 1990s, in the 2001, 9/11 really changed the kind of the focus on trauma centers because of the attack on the readiness that was necessary. So the concept of readiness actually was taken on by the American College of Surgeons, and in that time frame, during those first several years after 9/11, developed what's called the trauma activation fee. So that cost of readiness is born within that, and all our centers. When you call that, when you make that triage as at the level of response, those costs are billed to insurer.
Sure.
And
because you're drawing all those resources.
And that's
you're
what
committing
but
them
it's
to that
but
patient.
the important thing to realize is it's what allows us to maintain trauma centers.
Sure.
And provide the services.
Yeah, resources. We all, and I think we all understand. We had a good conversation about that off topic, and I think that's important. How when EMS activates a trauma, they know I'm securing all of these resources, and resources cost money, and we have to maintain those resources to have the better outcome. You know what I mean, for that patient.
And that's why accuracy of triage is so important to us, and try to get as much information in regards to make sure that it's in an appropriate level of activation.
Sure.
Yeah, and that was to my point with the EMS in this county. We don't have a quarterback at Geauga.
Oh, okay.
So when the EMS providers in this county are calling, we're leaving it to the receiving call at the hospital, whether it be the medic or a nurse or the doc, to triage that and then put out the trauma, whether it be limited or full. But I don't know that they know the terminology per se as to what would qualify that. Other hospital systems within UH, we have what's called the quarterback position that hears that called and then relays that and makes determinations based on trauma triage.
Yeah, and I think the big focus on the criteria is we're all doing the same thing, right? So if I put the criteria in the EMS provider's hands, like when we taught it at Portage, I joked about it a little bit. I mean, you got to make it fun with guys to pay attention. Is, I have a catch-up. That's the serious one because they're in a red. The full activations were in a red box. So if you had a systolic blood pressure less than 90 with a trauma-related injury, that's a full activation. That's real easy to convey to the nurse, medic, doc, whoever answers the phone, right? This is what I'm coming in with. Or I got more of a mustard on my hands. I got a rollover, 45-mile-an-hour crash, whatever, fall from said height. And you convey that, then we're all speaking the same language, and I think that's a huge part of it. So that's why we talk so much about criteria, so we don't over triage too much, right? Because then we overwhelm the center, and then we never want to under triage someone because that's where we want to try to prevent a bad outcome.
I agree, and I think that's why it's good to mention, at least in this county, that any county. I mean, if they're calling the hospital. Yeah. Give them what you have, give them the vitals, give them the story, and let them make a determination, not so much on my end because I might have 80 things going on. I shouldn't have to sit back and look at protocol real quick, unless you know it well, which you should, and say that this is a limited or full. Don't worry about that. Let the hospital worry about that when you give your narrative. But I would always suggest you err on the side of caution. Paint a good picture. Let the receiving staff know your vitals and your picture, and let them make a determination. But also never feel afraid to say this is going to be a full activation. If you know what you're talking about, like let them prepare for that.
Yeah, I think it's fair. Like John and I always talked about that too. Like if you call and say I have a trauma patient and this is why, right? Because I think I'm going to try to take your point is I don't want to look at this paper and be like it's not on this paper, right? You don't want to hand to that, but like this is a trauma patient. I'm inbound. I'll be there in 15 minutes, and then this is why. And then
you might only have a 5-second conversation, or even call dispatch and say, "Hey, call Giaga, put them on trauma alert," and they might not even know why. But
no, one of the truisms in this area is over triage. Indeed, is resource consumptive, but under triage is life threatening. So always err on the side of over triage.
Yeah.
And that's the point you're making.
Yeah, and no one's ever, when I am in the emergency department, whether I'm teaching or even talking to other colleagues, in the ER, I don't get in trouble for doing something, right? I don't get in trouble for CAT scanning or doing whatever. I'm going to really step in it if I don't do a test or if I don't look into something. That's when I get in trouble. Same for you guys.
But be open to constructive criticism if that's what it is. So if I over triage something, let the ER docs or the EMS coordinators get a hold of you and say, hey, why did you do that? And maybe this is what we do going forward. And if it becomes habitual, maybe then you have more conversations. But I mean, obviously no full activations for a broken finger. I mean, that's a bit overkill, right? So then you would have that conversation. Why? Okay, that's not right. Let's talk about protocol.
So my EMS agencies that I cover transport to 4 different hospital systems: UH, Cleveland
There's a
Clinic,
big difference there.
Akron, Summa, and Mercy out in Youngstown. All 4 of those have different criteria in different places. You guys can all identify a trauma patient. So I've got a trauma patient. Give me a GCS. Give me a blood pressure. Give me a heart rate. Give me respirations. Tell me what happened. The person on that other end of the phone call can then make the decision because they're going to know that hospital's activation criteria to go, oh, this is going to be a full, or if you're in different places, a level 1 versus a limited, which is a level 2. Then we could get really into the weeds of level 3s or trauma consults. Those are things that I think that I like to keep EMS out of that hospital business. But just give me what I need to know. GCS. I need to know vital signs. I need to know
and I think
what happened, and then I will do my activation as a hospital.
October episodes with Don Zimmerman when he talked about how they put a bunch of firemen with experience on that and said go triage.
Yeah.
And they didn't need tags or anything else, but they did so much better than the group that didn't have that that just what do you call it, the discipline or the knowledge there. They were new or whatever, and they said do it differently. It was the group of experienced people that triaged so well. And it was just that. They calling you and saying, this is what I have, and then you make your determinations.
Well, we realize that in all these triage schemes, discretionary EM discretion or trauma surgeon discretion is also included.
Correct.
So that's what you're talking about is, and sometimes it is experiential. You have to have some repetitions under your belt. I will say the only error we're allowed to make, and you talk to this, is the error of commission.
Yes.
We cannot make the error of omission.